It's the Ray Gibson Show, and 7 after 9 o'clock in the morning, and we come up to one of my favorite things that I get to do every month, and that is to spend some time with medical professionals, team over at Guam Regional Medical City. The segment of the program, it's actually got a name, is Your Healthcare Partner, and so vital that that you think in those terms. That a lot of times you don't think about your relationship with your doctor until you get sick, but there are people here that can coach you through the easy stuff, so you don't get to the hard stuff. And so we'll start in with this. Carla Haddock unfortunately cannot make it to the conversation, and we'll have to schedule her in for another time, Charlie, if you don't mind, because I think she's a great story of a girl from around here that has been able to do all of the things that she needed to do, nursing professional, et cetera, and just a fantastic human being. What do you got? What's wrong with the camera?
She's not in it.
Oh, she's not in it.
Yeah.
But she's not supposed to be in it. Him's supposed to be in it. That's all right. It's okay. Just put it in auto mode, and then we'll all be all right there. She doesn't need to be in the shot, but we're going to put her in there anyway. But like I said, anyway. So Carla, done everything to go through the nursing program here. Got herself some time with the Navy, I believe, and that helped contribute to the work that she's doing over at GRMC. So she's definitely a get for an interview in the future. In the meantime, returning star Dr. Joseph Wiedermann. Good morning.
Good morning.
Did I say it right again?
Yeah, you did.
Was it Wiedermann?
Wiedermann.
Wiedermann. Okay.
Wiedermann. It's too German with this hard W.
Yeah. I got that. Well, it's great to have you back in the studio, and because it was a great conversation that we had before. We generally tend to have a few things in common. We're both big believers in cardio health. You can tell by looking at him that he spends some time over at the beach as well.
I do.
And we were talking about a favorite. I don't know if I want to mention the place out by Tengisan that you were talking about, because if we start talking about it too much, all of a sudden it'll be the most crowded spot along Guam's great beaches.
Well, a lot of the local folks know about it. It's not exactly a secret. It's just basically a 10-minute hike north of Tengisan. Yeah. And it's a little, very private beach with two sort of mushroom volcanic rock formations and crystal blue water. Wow. And no people.
And no people, at least until we start talking about it on the air. But you've got a delightful tan, and so for me, every week I try to get out to a beach somewhere, Jimmy's, or I like a spot over by Gun Beach. It's a great place to go and watch the bikinis walk around, and there's always somebody that is snorkeling in the water. Unfortunately, these days with the wind the way it is, somebody actually got snatched out of the water by a Navy diver because he noticed that the guy was in trouble. So always be careful when you're out there. So I try to get to the beach as often as possible, and I'm probably going to get a scolding for this, but I'm not a sunscreen guy.
Oh, my Lord. My dermatologist yells at me all the time. Yeah. You should be using sunscreen.
Yeah.
I will confess to you.
But it defeats the purpose.
Yeah, I will confess to you that I never use anything more than number 4. Mm-hmm. And please, that is not medically wise. It's evil. Please don't do it. But I want a tan. So yeah.
That's right. That's right.
Yeah.
So I never use anything. Get out there. I've got this belief. It's almost childlike that this is my Guam sun, and I'm a son of Guam, so it's not going to hurt me. And besides, they closed the ozone layer, right?
It's still much stronger, the sun, than it was 20 years ago.
Yeah, all right. Well, that's the lie I tell myself so I can sleep at night. And near as I can tell, I don't have any strange bumps. There's nothing falling off the appendages, so I'm pretty sure I don't have anything like that.
If you're going to do what we both seem to do, which is laze around in the sun, you should see a dermatologist once a year and get a complete screening just to make sure there's nothing funny going on your back where you can't see it or other places.
Do we have dermatologists over at GRMC? Okay, that's the specialty care we'll work on. We'll add that to the specialty mechanisms over at Guam Regional Medical City. Doc here is you're a heart guy.
Indeed.
Okay, so so in the beginning of this, I said the first question I was going to ask was going to be about coronavirus, and he's like, well, that's not my specialty, but you have MD at the end of your name, and it must be an interesting conversation among the other MDs as we watch this coronavirus and its spread.
Well, often with a virus whose behavior is not really well understood, all of us in the medical community are wondering, exactly what the mode of transmission is, what the lethality is, which actually seems to be lower than we initially thought, how easy it is to transmit. And a lot of this is a work in progress. We're just learning about it. And for the moment, the appropriate thing is caution.
Yeah.
Attention to yourself if you suddenly develop a fever or
I'm touching my
cough.
face. Oh my God, I'm touching my face.
Well, you also haven't been in mainland China, so unless you've been exposed to a tourist from mainland China or who was recently there, it's unlikely that your flu is going to be due to coronavirus.
Yeah.
But if you've been exposed, it's certainly worth checking out. And, a level of suspicion is important.
Well, when we say checking it out, I mean, what have we got to check it out with? My understanding is that there are kits on the way. They're not here yet. And even if they do come here, we've got to vet those test kits to make sure that they're looking for what we want to find.
Unfortunately, that's true. I mean, again, I would defer to an expert such as Dr. Yamamoto, who's our ID person at GRMC. But at the moment...
ID is infectious disease.
Infectious disease,
okay.
Yes, I'm sorry, medical abbreviations. At the moment, I would say if you think if you have been exposed, if there's a concern of exposure, then unfortunately, coming in and probably accepting a quarantine is the way to go.
Yeah.
Because it's not just a question of whether, you're sick with the virus or not, but the risk that you might infect other members of your family or friends or neighbors. So caution is recommended. But again, we haven't had a case on Guam yet. So,
thank goodness. Knock on wood.
Correct.
So what the thought that I have as I'm going through this conversation is, I worry about the capability of the island, our hospital, our current healthcare environment to be able to take care of something that could turn into a large-scale epidemic. And then the other concern that I have actually has to do with people like you in the healthcare industry. What are you doing to make sure that you're not getting sick? I mean, are you not touching your face, or you got the hand sanitizers? You find yourself washing your hands a lot?
Well, right. Well, the fact of the matter is you should be washing your hands before and after every patient encounter anyway. I mean, that's part of normal medical hygiene. So, yes, of course you wash your hands. And, frankly, if you're going into a room with someone who's coughing, on Guam, it's much more likely to be pneumonia or tuberculosis than it is to be coronavirus. And we use masks anyway. So following standard procedures and being strict about doing it will prevent medical providers and other people from getting the virus if it appears.
As if it's a good idea any other time of the year, it's a good idea now. Watch what's happening with your cough. Maintain some basic sanitary. I wouldn't run out and get a mask unless you happen to be around people that have been traveling to those areas with infection. Otherwise, you're throwing good money after bad. Take the mask, buy the mask if you feel like you have to, and then hold on to it until you actually really need it.
Yeah, that would make sense. And again, the rule of thumb is when you hear hoofbeats, don't think of zebras, right? In all chances, if you have a cough, you just have a cold, all right? The chances of it being coronavirus are actually quite low. If you have been exposed to someone who's been traveling, it may be something to think about, but that shouldn't be the first thought in your head.
Yeah. Is that it's AIDS or cancer or something like that? 888-8255-888-TALK. So, guy's a cardiologist. That's a heart doctor, and they do plenty of heart work over at Guam Regional Medical City, and so we're going to find out a little bit more. And he's been in the studio before, and I've always been amazed by the gee-whiz technology that is available on Guam over at GRMC. But you've got new stuff now. You have new toys there?
Well, we have pretty much what we need to do state-of-the-art coronary intervention and peripheral vascular intervention. So we have, if you have blockages in the artery supplying your heart, or equally in the artery supplying your legs or your kidneys, which people also develop blockages in, we can fix that with balloons and with stents, but we can also do things that allow us to image the artery from the inside. Not just angiography, which uses dye to take pictures. We have small intravascular ultrasound catheters that are miniaturized sonograms that we put inside the arteries. We can actually look at the lining of the artery, see what the blockage looks like, if it's calcified or soft, determine what best equipment to use to treat it. We also have...
no, you don't. They haven't invented that.
Indeed, they have many years ago, but we just got it not that long ago.
That's something else. So it's kind of like the guys over at it's a clumsy analogy here, but the guys over at the GWA have got systems, little pilotless drone things that they can, on wheels or whatever, and they can go through the pipes and look to see areas that are blocked. They can look to see areas that are cracked where there might be leaks and things like that. So we're doing the same thing at the intravascular level now?
Yes. I mean, one of the drawbacks of angiography, of just taking pictures, is it basically takes a tube and fills it with a dye that shows up black. So you're getting a two-dimensional image of what's essentially a three-dimensional object, and you can't see fine structural detail in the artery at all. This catheter, which is tiny, travels down the artery over a wire, will give you a picture of the inside of the artery with extraordinary resolution. You know, people are used to having ultrasounds of their babies.
Yep.
This gives us even higher resolution. We can see whether a plaque is calcified or lipid rich. We can see whether it involves the bifurcation of a vessel. We can see after we put a stent in whether the stent is fully deployed and up against the wall of the vessel, or whether we need to make it bigger. So it's a device that increases the safety of our procedures and gives us a better sense of what we're actually treating.
Do they have, outside of being able to observe, does it come with a utility belt? So when you need to inflate the stent a little bit more, or where you need to remove a blockage, does it have something that you can whip out and say, okay, I'm going to laser this, or I'm going to high frequency that, and get rid of it?
Well, the ultrasound device itself doesn't, but the ultrasound device travels over a guide wire, which is put down the artery. So I do the image, I pull out the ultrasound catheter, and I replace it for either a balloon, a stent, or a rotational atherectomy drill, depending on what things look like. So it's very easy to switch out equipment once you have a wire down the artery.
So the rotational, what did you call it?
Rotational atherectomy.
This fascinates me.
Right. So this essentially is a drill bit, a diamond-studded drill bit that spins down the artery at about 180,000 RPM, and it's used to take off calcified blockages. So some people develop plaque because of accumulation of cardiac risk factors, hypertension, diabetes, smoking, high cholesterol, and depending on age and other circumstances, that plaque can be soft or hard. If the plaque is hard or calcified, it can be difficult to open it with a balloon or with a stent because it just won't dilate.
Yeah.
So this drill will take the calcium level off, and then the artery becomes more compliant, and we can treat it with a balloon or stent conventionally after we've drilled it first.
As I say, it's fascinating to me because we're talking about a piece of metal in the body, diamond tip on it. How does it know the difference between what it is that it's supposed to be going after and the soft tissue of the vein, the artery?
Right. So this is very similar to the technology used in a cast saw. It's called differential cutting. It will preferentially cut hard tissue and will basically bounce away from soft tissue. So it's going to cut the calcium, and it doesn't actually do much cutting at all in soft tissue. Just the way a cast saw will cut the cast and stop when it hits your skin.
I didn't know they had that either.
Yeah, that's old.
But I'm again, you know, the clumsy analogy. There's a table saw I think over at Home Depot that you can get, and it knows when it's cutting wood, and if it gets too close to soft tissue, it will detect that it's not hitting wood anymore, and the blade will stop immediately. Same difference, but at an infinitesimally smaller level.
Yeah, well, the diameter of the drill bits that we're using are essentially, the smallest ones are 1.25 millimeters. So we use 125 or 1.5 burrs to take off the calcium level. So they're very small. They're much smaller than the total diameter of the artery, because we're really only treating the narrowed portion that's calcified.
Well, what happens to the calcium after it gets knocked away, after you drilled it out?
So that's an excellent question. What happens is the drill bit pulverizes it to micron-sized particles, which are actually washed off downstream into the capillary bed and leave the heart and eventually get processed in the liver. But they're so small that they wash out downstream.
Unbelievable. This is it flabbergasts me here, because this really is some gee whiz technology stuff. I mean, you'd think there would need to be a filter to catch whatever was going out so it didn't become a problem somewhere downstream, but it actually breaks it up into light-sized pieces of calcium.
It breaks it down into such small particles that mostly it washes out. In some people, if there's a large amount of particulate debris, it may cause some sludging. We have some chemicals which can dilate the distal coronary circulation to wash out the particles if there is sludging. So that can happen sometimes where we see slow flow in the artery after rotational atherectomy, and we can treat that with medications.
All right, so how do I know when I'm at that stage? What happens before we start in with that nice drill and you know, your cool camera?
Well, the issue is really whether you have a blockage in your arteries that requires treatment. And the threshold for us is any blockage over 70% is enough that it'll impede your ability to get blood flow during exercise, could potentially cause a heart attack. Anything less than that, we can treat with medications. And with statin therapy, there's good data that we can see regression in plaque. So if we catch a plaque in the 40 or 50% range before you actually have symptoms, and we keep you on statins, that 40 or 50% plaque 5 years later could be a 20% plaque. So early detection is important. In terms of what we do to figure out whether you have a plaque that requires treatment, it's really a question of symptoms. You know, are you getting chest pain when you climb a flight of stairs? Are you getting short of breath when you walk too far? And is that new? And is it also, I mean, again, if you're getting short of breath because you weigh 400 pounds, that's one thing. But if the shortness of breath is new, if, you know, 6 months ago you didn't feel that way and suddenly whenever you walk a few blocks you're short of breath, that could be the same as chest pain. Some people get chest pain, some people get shortness of breath as a symptom. So if you get one of those symptoms, you should see your doctor. You probably need an echocardiogram to look at heart muscle function and a stress test to see if you have blockages. If the stress test is abnormal, then we would proceed to angiography and take direct pictures of your artery and see if you need something fixed.
All right, a couple of questions based on some of the points of the topic is you were talking about the calcification, the blockage that is hard, and then the softer one. What do we do in the case of the soft blockage?
Again, the soft blockages are usually blockages that are very lipid rich. So there's a big core of fat or cholesterol in the blockage. Those blockages, frankly, are more likely to rupture and cause a heart attack because the plaque itself can rupture through the outer layer of the blood vessel and cause clotting and cause a heart attack. But in terms of treatment, they're easier. Because we just balloon them, stent them, and that's it. And then we put you on a statin to make sure it doesn't come back.
Simple process. Okay, I kind of like that. And then on the subject of chest pain, and I don't know, maybe it's just because I have had more than 55 birthdays or so, you start to get real cognizant, real aware. And, you know, I was always under the impression that you shouldn't feel any of your internal organs. But every once in a while, you know, you sleep wrong, you wake up on the wrong side of the bed, maybe you just had a hard time with a hike or something like that, and all of a sudden you just get a sharp pain over here, goes away.
If you're getting a sharp pain that goes away, it's not your heart. It's almost certainly musculoskeletal. Cardiac pain tends to be reproducibly exertional. That is, you get it when you do something physical and it stops when you rest. Generally, it feels like pressure or burning, and it doesn't come and go that quickly. It usually lasts 5 or 10 minutes until you rest and it goes away. So, you know, again, if you're getting that kind of a symptom, that's something to see a physician about. If you're getting little sharp evanescent pains, it's very unlikely to be your heart. I mean, it could be something else worth looking into, but that's not a typical cardiac symptom.
Well, just one of those things that comes along, and I guess the conventional wisdom is after a certain number of birthdays, you're going to have certain pains, and it's important to be able to catalog those things. Also important to be able to talk to the doctor about what those pains might be, and maybe a little bit more about your history. Speaking, I suppose, in those generic terms, there's a difference between the way men will experience that chest pain and women will experience that chest pain as it leads to a heart attack. Are there not?
Well, it would be more that women often get symptoms that are not chest pain. In other words, men classically have chest pain as a symptom of blockages. But again, when we say that men classically, we're talking about 80, 85%. That still means there's 15% even in men who have weird symptoms. I have one patient whose angina, that is their symptoms from not having enough blood flow, is reproducible earlobe pain when they walk up a hill, right? So you don't always know for sure, and people can be different. Women more likely have atypical symptoms. Again, even in women, more than half the time it's chest pain. But that other half the time, it can be abdominal pain, severe nausea, just feeling
be
weak.
Careful. I mean, those are shared symptoms with all kinds of problems.
Correct. But again, in a woman of a certain age, and by a certain age, I generally mean postmenopausal, because your risk goes up after menopause. If you have risk factors for heart disease, which basically means high blood pressure, high cholesterol, diabetes, smoking, these are things that if you're getting symptoms, even if they feel a little bit odd, if they're new, go see someone. Because women certainly have a higher incidence of atypical symptoms than men.
But that's we're talking about women, the postmenopausal women, and the ladies in the broadcast are going to be giggling here because they go, "Oh, this is the part where Ray thinks he understands what happens in a woman's body." But there's a lot of changes that take place pre and postmenopausal. There's a lot of the hormonal changes that go on in a woman, and so it's easy for some of those symptoms that you're talking about to be disguised, to feel like something else.
Correct.
And go to a doctor, and the doctor says, "Well, you're 48, you're 49, you got menopause. There you go. Congratulations." And not necessarily look into the heart.
Right, but it's not going to be like your hot flashes are not a symptom of heart disease. It's not that. It's just that once you're past menopause and you're deprived of your estrogen is really great. And one of the things it does is it raises HDL cholesterol, which is the good cholesterol and protective. So once you're, 5 years past your menopause, your risk of having heart disease, which used to be lower than men's, now becomes the same as men's. So we need to be more attentive. But if you're having symptoms, and the symptoms really would be exertional shortness of breath when you walk, chest pain, or you're just feeling much more weak and tired with less exercise capacity, it's very simple to get a stress test. And the stress test may turn out to be normal, which is great, but then at least you know. So all I would say is don't ignore new things. Don't just say, "Oh, I'm getting older." Have it checked out.
Is there a pill you can take to keep the estrogen level going?
You can. Again, that's something to discuss with your gynecologist. There are some downsides to estrogen replacement as well. There are increased risks of certain cancers. Now, that is much less than it used to be because currently estrogen progesterone replacement doses are much, much lower than they were 10 or 15 years ago. So, in some people, low-dose replacement may be the right strategy, but that's something to discuss with your gynecologist.
All right, a couple of other questions is we don't talk about heart health without talking about diet and exercises. So we'll start because we'll do with the diet. I'll say because in my mind the diet's the easier one to do because exercises it's built in for marathon runners and things like that. But on the diet, what do I need to do? There was a study that came out that basically, and we talked about this the other day on the radio, that basically debunked everything that we'd been told since the 70s about red meat. And they said red meat's not so bad. They were looking at the numbers and the way they did the research, and everything was going to come out bad based on the way they conducted that research. So go ahead and eat as much red meat as you want to. Yesterday's PDN had a story about, hold on just a second, we still think that there's alarms that should be raised when we're talking about red meat and that heavy protein in the diet. What do you think, Doc?
Listen, the fact that there's one study.
I've seen this guy eat his crust, by the way, so I know what he puts in his mouth.
The fact that there's one study that raises some questions. I mean, there's hundreds of studies showing the link between cholesterol and heart disease. So I would say eating red meat once in a while is not an issue, but red meat is a huge source of cholesterol. So it's a big problem. Again, it depends how often you eat it and what your actual cholesterol level is. So if your cholesterol level is normal, then obviously what you're eating is not that much of a problem. If your cholesterol level is elevated, then you need to be careful with red meat, and that includes pork, which despite the marketing is a very high-fat meat. And it includes all forms of red meat, beef, pork, lamb, the whole thing. Chicken and fish is generally okay. The other big culprit foods in terms of cholesterol are milk, butter, eggs, and cheese. With eggs, it's the egg yolk. So again, those are high cholesterol sources that should be avoided if you have high cholesterol.
Yeah, you and I can't shop together.
Well, I'm not saying that that's the way I eat. But I'm not using myself as an example here. I'm telling you what the right thing to do is. And the right thing to do is to watch your cholesterol input.
I was eating deviled eggs the other day. Payless has got this tray, and it's basically 4 deviled eggs, cut in 4 actual eggs cut in half and devilized. And I ate all 4 of them in one sitting.
Right, and if you do that once every 2 weeks, it's no big deal at all.
Okay.
If you do it every day, your cholesterol is going to go through the roof.
You know how I am with cheeseburgers, right?
I understand the whole appeal of cheeseburgers, but again, the issue is moderation.
Yeah.
And also, it's not one size fits all. Find out what your cholesterol is, and then we'll tell you what you can eat.
In terms of diets, there's all kinds of different diets out there, and I got to bring this one up because I generally, based on my schedule, it works out for me, but I intermittent fast. I don't eat anything for breakfast. I might have a light snack or something like that at lunch, maybe, or something heavier like deviled eggs and cheeseburgers, and then nothing for dinner. So if I eat a lunch, I don't eat dinner, and if I don't eat lunch, then I eat a dinner, and it's usually just that one meal a day. In terms of intermittent fasting, is there any benefits to your cardiological life if you're an intermittent guy?
Well, I'm not sure that there's a cardiological benefit, but there is some data that suggests longevity benefit for intermittent fasting. Yeah, this is an interesting and developing field, but there is some data that suggests that if you are able to fast for 16 hours on a regular basis, that is, you space out your meals so that you have a 16-hour meal-free period, there's actually data suggesting there's an increase in longevity. So we don't really understand why that is, but intermittent fasting is not a bad approach, not in terms of cardiovascular health, but in terms of long-term metabolic health. There are a number of studies on that issue, and it's a field of ongoing research.
What about a patient? Bill is asking, what about a patient is told they need a bypass? It's a clunky question, but I think I understand what he's saying. Are we at to a point yet where we can eliminate bypass surgery?
No, not really, because again, I can put in 1, 2, 3, 4, 5 stents in the same patient.
Yeah.
If I start putting in 10, 12, 11 stents, each of the stents has a certain risk of developing scar tissue. And particularly in diabetics who are at higher risk of developing scar tissue, it's been shown that if you have multivessel coronary disease involving all 3 arteries, people do better long-term with bypass than with stenting. So there's certainly a cohort of people who do better with bypass surgery, especially patients with multivessel coronary disease involving all their arteries and with evidence of previous heart attacks with depressed myocardial function. Those people will do better long-term. Their long-term survival is better with bypass.
That feels like such a kind of nuclear option when it comes to care. And so that, you know, some of the best advice that you're going to get in conversations like this with our friends from Guam Regional Medical City is, you know, take care of your diet, get the exercise that you need, get some baseline numbers, and maybe go by GRMC and work out a physical where we can do some stress tests, see what's actually going on, and if you need to, some of the non-interventionary the surveillance that you can do intra-lung, or not intra-lung, but intra-artery that they can do over at GRMC. Fascinating stuff. We'll talk about exercise, I think, when we come back. I'm going to take a real quick break here because it's 9:34. That's iConnect time. Run by the nearest iConnect and ask them about saving you some money. Or better yet, here's the idea, and I'm going to look over. What kind of watch are you wearing?
None.
You're not wearing a watch. He's not wearing a watch. Just, you know, this is going to derail the next line of questioning here, but I'm gonna hold on to the questions anyway. Apple Watch 5. I told you about this yesterday. The latest issue of Runner's World magazine. The editors are all playing with, testing, and loving Apple Watch 5s. And these are people that, you know, they need the surveillance, the data that you can get from the phones, from the Apple Watches, and different things like the EEG or the EKG that is on that. We'll talk about that. There's cool ways that we're using technologies these days. You can get an Apple 5 watch, I believe, over at the iConnect at the Micronesia Mall.
GRMC's cardiology department treats most complex heart problems. In our catheterization lab, cardiologists use imaging equipment to treat clogged arteries that can cause heart attacks or heart failure. We perform balloon angioplasty, stenting, and other life-saving cardiac procedures. If you suffer from a heart condition, have your provider refer you to GRMC's cardiology clinic at 645-5500. GRMC, where patients are partners.
Passwords, they're the keys to our online identity, whether it's to your social media profiles, our streaming services, or our bank accounts. Here are some tips to keep your passwords strong and secure. Change your passwords often. Never use the same password across different websites. Craft your passwords from phrases that only you understand. Refrain from using characters or numbers that are right next to each other on the keyboard. These password protection tips are brought to you by Bank of Guam, member FDIC.
What, is it time for me to talk? Is it a commercial? I don't want to do a cheeseburger commercial with the guy in here. What? Fine. All things in moderation, and I would say that about once a week's a good enough schedule for the Big Bacon Classic that they've got waiting for you over at the Wendy's place. A couple of them on Guam. But all right, here's the thing: you can go and today you can go, because you can go to Wendy's every day. You can today go to Wendy's and get the Big Bacon Classic. Tomorrow, salad. And they've got all kinds of great salads. My favorite is the apple walnut salad, because it's got a lot going on in there. And you can have that. You can get it with the fried chicken if you want, or you can ask them to bake the chicken for you. And that will be the healthy alternative for you today over at Wendy's. Now, that's better. Very close, very dear personal friend Kenny Williams in Facebook Live asking a question. Hi, guys. I've had an aortic valve replacement. Am I allowed to scuba dive? What do you suppose, Doc? Is that in the lineup for him?
A couple of questions. First of all, is it a mechanical aortic valve replacement or a biological one? Is it a tissue valve or a mechanical valve? That makes a little bit of a difference. The issue is whether you're on a blood thinner. So if you are on a blood thinner, which you're on for mechanical valves, but not necessarily for tissue valves, it does increase the risk of scuba diving, particularly at significant depths.
Right.
So if you just have a biological aortic valve prosthesis, scuba diving is not a problem. If you're on an anticoagulant, it's something to discuss with your doctor, particularly for deep dives.
Yeah. Anything below a few atmospheres, huh?
Correct.
Yeah, where you got some real pressure going on in the soft tissues that and the blood as well. All right. Well, a good question there. Sabine says I get out of breath so fast, and Kenny says it's mechanical. So yeah. Yes, warfarin. I don't know what that is. But anyway, yeah, it's a mechanical one. Sabine just saying she gets out of breath so fast. I don't know what age group would put her in, but if you're getting out of breath, doing things, as the doctor says, that are fairly normal for a person your age. I mean, you're not running a marathon. You didn't just finish a 5K and you're short of breath. But if you're just, from the car to the front door of the grocery store and you're getting out of breath, that could be a problem.
Yes, it could. It could be a heart problem, or it could be a lung problem, but it's worth looking into.
All right, 888-8255 is my telephone number. Facebook Live, if you got some questions, and Chalarna Laurent is online. So if you've got some questions about being able to maybe go see Dr. Wiedermann and the folks over at GRMC, that's the contact. You can ask for questions and make arrangements on Facebook Live right now. So we were talking a little bit about technology. A little bit. I was going to go into the exercise lecture, but I think I'm going to bypass that for just now because of the conversation on technology. When I was a little boy, we had watches that you had to wind up, and if you forgot, it would just go south. Now it's 2020, and they've got watches that will tell you the barometric pressure. It'll take your heart rate. It will tell you what your pulse is up to. And the Apple 4. A friend of mine actually found out he had AFib because of a little app on the Apple 4, and I thought, well, that's kind of interesting that we're using it's shelf technology now to do things that years ago would have required a visit to the doctor's office. You've been reading up obviously on that technology and being able to detect heart issues with wearable technology. What are your thoughts on that?
Well, the Apple Watch in particular, the algorithm used for atrial fibrillation detection on the Apple Watch has been validated in medical studies and is actually approved by the FDA as a monitoring device, which most watches aren't. So I would say that using the Apple Watch for detecting arrhythmias is not an unreasonable strategy. I mean, you should see your doctor. We do have more accurate monitors that can be placed that really just require a small patch that you wear on your chest for 2 weeks, but it detects more EKG leads than the Apple Watch. So the Apple Watch is limited. There are, just as a basic rule, EKG leads that give us detection of 12 different vectors. So an EKG will definitely usually have 12 different vectors that we're monitoring, whereas the Apple Watch will only monitor
what's on the wrist.
A couple. It doesn't give you a full reading of the EKG, so it's useful for detecting arrhythmias. It's not as good as some of the monitoring devices we use, but as a preliminary device or as a way of seeing whether your medical therapy is working. In other words, you had atrial fibrillation, you were treated, you're out of it, and we want to see if you're having blips where you go back into it. Things like the Apple Watch are a good idea, but they shouldn't just be done ad hoc. You should coordinate that with your physician.
I see. Well, I've got it for, and I checked myself on that watch, and it said I don't have AFib. But every once in a while, there's a couple of other buttons that you can push and see what your actual heart is doing and what it looks like. And I think that's pretty cool at the end of the day. And as an athlete, I've got a Garmin. Today I'm wearing a Garmin, but I have run and been able to maintain records with Strava and things like that on the Apple Watch. So I'm kind of intrigued at the idea that we've got these things out there that can surveil what my body is up to. When I first started running, and I'm sure it was the same with you, if you wanted to see what your heart rate was doing for testing purposes or for training purposes, you actually had to wear a heart rate monitor across your chest. And anymore, you don't need to do that. It's all on the wrist.
Yeah, and the other thing about those watches that's kind of nice, but Fitbits will do the same thing for you, is, again, our recommendation about exercise is 30 minutes of aerobic exercise 5 days a week. Yeah. And the impact of that is a 50% reduction in mortality. So it's a big deal to do that. Some of these watches will basically be your nanny there. It'll tell you how many minutes have you put in. Did you really raise your heart rate? Because it doesn't count as exercise if you didn't raise your heart rate.
Yeah, the Apple is a nag. The Apple is a complete nag. 2 or 3 times a day, I'm told to stand 2 or 3 times a day. I'm apparently not breathing enough. Now, I don't know whether that's is a timing thing. It just says, or whether you get into some of those moments where you're breathing a lot slower. My heart rate's not that jacked up on a regular basis, so I'm not sure that I'm breathing at a regular rate. And I guess the watch is now telling me that.
Listen, the breathing thing, it's kind of cute, but there's really no medical data that correlates with that. The thing about standing up is a different story. Basically, that's a way to reduce your risk of getting a blood clot in your legs, getting a deep vein thrombosis. They're making you get up because immobility increases the risk of getting blood clots. Now, generally, we don't see that except for really prolonged things like airplane flights. Yep. But common sense is every couple of hours you should get up and stretch your legs. Then you'll never get a blood clot.
That's the idea. Well, and deep vein thrombosis is a thing and was something that people were worried about for a long time. I recalled back in the days when I was doing a little bit more traveling than I am now and longer distances. I was always worried about DVT and just the discomfort of sitting on an airplane chair for so long. I'd pop a couple of aspirins and thought, all right, well maybe that'll thin things out enough and keep me at least from getting annoyed of being stuck in the chair for a while. Anything to that?
The aspirins are unlikely to prevent it. Getting up will prevent it.
And it's cheaper.
DVT really is an ongoing concern. It happens all the time to lots of people. The problem is not just that the blood clot forms in your leg, but that it often we're talking about 40% of the time, will break off and go to your lung and cause a pulmonary embolus, which can occasionally be fatal. So the simplest thing to do, and all of us who come back and forth to Guam, get up. Don't sit there in that airplane for all those hours. Yeah. Every couple of hours, get up, walk back and forth to the bathroom.
Same thing can be said sitting in an office too long. There are people that are stuck at their chairs, and enough people, internet surfers, that spend a lot of time tapping away at a keyboard and basically sedentary for literally hours at a time. Get up, move around every once in a while.
Yep, absolutely.
Are there other things, as a cardiologist or as an MD, are there other things when we start talking about technology that is attached to a human being all the time? Would you like to see more of that, or are there gizmos that some kind of telemetry? I imagine in the future that there are going to be big rooms full of people that will be watching my watch and seeing where I am, what my circumstances are, what my heart is doing, what my other organs are doing.
Oh, that is not in the future. That's already ongoing.
Oh, boy.
We have multiple implanted devices that we can surveil now through the internet and, in fact, give instructions to through the internet. So if you have a pacemaker, a defibrillator, or even an implanted insulin pump, those can be programmed by internet. Parameters can be changed by internet. And I will tell you guys a fun story that there's even been an attempted murder by internet by overdosing with an insulin pump on a hacked insulin pump device.
Oh, my.
So there's all kinds of technology that's in your body that is being controlled externally, which requires protections because your doctor is not necessarily the only person who can access it.
That sounds like an episode of, what is it, Black Mirror, Dark Mirror, something like that?
That has already happened.
Wow.
Yeah, so again, there are incredible advantages to having this technology be programmable because we can change the parameters of your pacemaker. For example, if you need to exercise more, we can change defibrillator parameters, we can change insulin doses. But this thing of external control of implanted devices, that's already here.
Yeah.
It's just going to get more advanced as the years progress.
You need to have bank mil-spec protection and firewalls in between the bad guys and the things that are in your body.
Correct.
Wow, fascinating conversation. But so I get going back to the question though. Are there other things that you would like to be able to either implant or monitor? I mean, as a cardiologist, are you waiting on a new kind of technology that will allow you that 24/7 ability to see what's happening?
Well, one of the things that people are working on would be very interesting is a small implantable device that goes in a vascular structure and that measures vascular tone. And in that way, we could externally continuously monitor blood pressure. So that would give us a better idea of how well controlled a patient's blood pressure is on medications, because basically our view of that is a window when they come into our office, and they're always nervous when they come in our office, so it's always a little bit higher than it should be. So continuous implanted blood pressure monitoring is something that will be available pretty soon.
Very nice.
Yeah.
So the dreams do come true, the holy grails of all of those. In terms of detection, we're talking about all of the things that can build up in your body. I remember I went and had my eyes examined by an ophthalmologist once upon a time, and the guy made a reference to a thing called the Arcus. And I thought, is that something I got to worry about? And he said, "Now you're too old for it already. If I'd have seen this in your eyes in your 20s, then we would have had a problem. We would have had something to talk about." But apparently there's places in the eye where little fat rings will deposit, right?
That can happen. Again, that relates to your cholesterol levels. But you can certainly see fat deposition in the eye, both in the sclera, the white portion of the eye, and occasionally arcs in the iris. That can be an external sign of cholesterol being quite elevated in your body.
Is that something you look for in your patients?
Yeah, but to be honest, we've usually detected it long before you get that. The exceptions are people who have a genetic abnormality where they really have familial hypercholesterolemia. They may present with those eye findings by the time they're teenagers. So, if you have a genetic abnormality, that may show up very early and it's an important sign. Usually, otherwise, we've picked it up long before it shows up in your eye.
Now, as a lawyer friend of mine who once upon a time told me that doctors can also look at somebody's earlobe and say, all right, that's a candidate for a heart attack down the road. Is there anything to that old wives' piece?
What he's talking about is a finding in the earlobe that is referred to as a coronary crease. So some people have a crease in their earlobe.
I do.
And there is some data suggesting that people with coronary creases have an increased risk of heart disease. Let's just say that there is epidemiological data to support that. It's not widely used. It's one of those things that professors like to torture medical students with.
I like that. So a little bit about your backstory. Where are you from, and what is it that got you thinking about becoming a doctor?
Well, I actually originally was born in Romania, but came to the States when I was very young. The reason that I decided to become a physician, frankly, is that my grandfather, to whom I was very close, was a physician and basically came home from work singing every day. He was happy all the time. He loved his work. Yeah. And he actually had his office at home in the apartment, and then also was a researcher at Columbia University. So I would see him all day long, and he would be super happy all the time. Yeah. Plus, the patients all seemed to love him, so as a role model, it was great. Nice. But it is a family with a lot of doctors. A lot of my uncles were also doctors, so it was sort of the family business. Interesting. And you go to school for a long time to do all that stuff. How surprised would your grandfather be if he followed you to work one day? Oh, I think he would be delighted by the technology.
Yeah.
I mean, he really was. He was one of the first people to publish papers on immunotherapy of cancer for bladder tumors. So he was very advanced in the field, and I think he would love the toys.
I'll bet. I'll bet. And isn't it great to work someplace where they've got the toys for you?
Absolutely. It's been a real pleasure working at GRMC. They're extremely committed to really providing state-of-the-art care for Guam. No excuses of, this is Guam, we can't do that. We are really doing everything I would be doing on the mainland.
Right. So have you ever had to send anybody off island?
Well, we do have to send people off island for bypass surgery. So that's something that, that's not going to change unless we get a bypass surgeon on Guam. And to be perfectly honest...
Not enough business.
No, it's not that there's not enough business. It's more complicated than that. GRMC made a very serious effort to build a bypass surgery program in the last year. And frankly, the problem is not the business. The business, sadly, is there.